Yes, we are live. All right. Good afternoon, everyone. It is 1 o'clock. I want to say thank you. We're going to be talking about policies and technology this year. I think it's been it's been a whirlwind 18 months actually with the pandemic, but this year specifically, there were a number of policies and changes in technology that occurred that really impacted the trajectory of the healthcare industry. So we're going to give everybody a couple of minutes to join. We do have a pretty large audience this afternoon, so we'll just give everybody a couple of minutes to join and connect. In the meantime, you can enjoy our beautiful slide. If this is your first time joining us, I want to welcome you to the Executives for Health Innovation webinar. If it's not your first time joining, you'll notice that our name has changed. We had a name change a couple of weeks ago, a rebranding, and it's really reflective of the change the organization is going through, and probably more importantly, the change that healthcare is going through. So we've gone from a little E to a big E, and we now are calling ourselves Executives for Health Innovation, but we will always be affectionately known as EHI. So for those of you who have joined us before, I do want to say welcome back, and if it's your first time, welcome. Today we have really great presentation and really great insights from speakers that are planned today, and I will soon introduce them. I will also introduce myself. I am Wynne Dixon, the Director of Programs and Strategy here at EHI, for those who've already joined. And we'll just give a couple more minutes for people to log on. As we all know, Zoom is not always the most reliable. Technology isn't the most reliable, and it does take a little bit of time. And I want to make sure that nobody misses anything. If you want to tweet what's happening today, you see our handle here at eHealthDC. That hasn't changed, with a little Twitter down there. Please feel free to share on Twitter and hashtag and give shouts out to for the webinar today and our wonderful speakers. We're in DC. It's a very cold day, which is disappointing because yesterday it was almost 70 degrees in the afternoon. And if you can't tell, I'm wearing a turtleneck this morning or this afternoon because it's 30 degrees outside. And so there was like a 30 or 40 degree differential between today and yesterday. So I don't know where everybody else is, but if you're someplace warm, please, oh, see, it just started snowing. Janice said it just started snowing. I don't want anyone to send snow here yet. What I would like is for everyone to send sunshine if you can. That's what I would appreciate. A little more sun, just a little bit more sun. Wherever you are. And I see the numbers still going up. We'll get started officially like in a minute or so, just giving people some more time to join. We're 3 minutes after. Rainy Portland. I think I can handle the rain. Thanks, Isabel. I will send you a little bit of sunshine I have. 'Tis the season to share the weather as we get ready for Christmas. I can't believe that it's December 8th. We are 3 weeks away for Christmas. I can't believe it. After Christmas is the new year, and we will be in 2022. I don't know about the rest of you, but 2021 went as fast as 2020, and I'm sure that 2022 will be even faster. All right, we've got a good group here already. So it's like 5 minutes after. I'll just go ahead and get started. Again, welcome. My name is Wynne Dixon. I am the Director of Programs and Strategy here at the Executives for Health Innovation, still affectionately known as EHI. And today we're going to talk about the policies and technology that connect healthcare data. What lies ahead? Where are we? What have we already experienced? And what should we be thinking about? Can we go to the next slide, please? So while we're advancing the slides, just a few housekeeping rules. Everybody is on mute. If you have any questions that you'd like to submit, please submit it to the Q&A at the bottom of your screen. If you have any technical issues or would like to share any resources while we're going through, please put it in the chat. If you see any questions in the Q&A section that are of interest to you, check the like button and we'll put it to the top, and I'll make sure that we get to it. Are we advancing the slides? Next slide. Okay. So it seems like our slides are not moving right now, but that's okay. I can talk through it. Quite all right. So this is so today with me, I have three speakers that I think are going to be very amazing for you. And our agenda really is to hear the different perspectives about healthcare. And before I get there, I do want to tell you a little bit about Executives for Health Innovation. We are a small but mighty nonprofit, and we tend to bring these. Oh, okay, everybody else is seeing the slides advanced except me. Okay, well, I know the presentation, so. Well, this will be me passing my test. They're not advancing for me. But we often host these programs, educational webinars, because that is our focus: education, advocacy, and thought leadership. And so this is how we share education and advocacy, is through our webinars. On our website, ehidc.org, there's a list of upcoming events that you can register for. And there's some things that have already taken place in the past that you can also take a quick look at. So quickly, I'd like to introduce our three speakers today. Because I don't see the slides advancing, I'm just going to introduce the speakers. We have Ruby Raley. She is the VP of Healthcare from Axway. Axway is our sponsor today for today's program. So I do want to say thank you to Axway, and thank you for the sponsorship. We also have Janice Karen. She is the Director of Integration Technologies from the Massachusetts Health Data Consortium. And finally, last but not least, we have Mr. Colby Tyner. He's the Manager of Health Policy from the Council for Affordable Quality Healthcare Incorporated, also known as CAQH. For that, I do want to say thank you and welcome to all of our speakers, and thank you for joining us today. We can pull the slides down. And I'd like to start with Ruby. Ruby, you oftentimes, we've talked a lot, and I know how you feel about transformative healthcare and how you feel about a number of these regulations and policies. And I know that you have a lot to say about it, and you're very passionate about it, and we've had a number of very interesting conversations. So I'd like to just hear from you, talking about this change and complexity. What are you seeing? What are the things that we should be talking about now, and what's coming at us?
Yeah, hey, thanks, Juane, and thank you everyone for joining us. We always have such great conversations. I'm looking forward to answering questions, talking to each of you, and hearing from my co-panelists. Yeah, this has been interesting, right? So let's kind of stand back a little. It's the end of the year. It's nice to reflect. Let's stand back a little bit and take a look at what's happened. So we had three transformative regs that sort of started. They weren't all passed this year, but the regulations started being published this year. The interoperability rule with the requirement for patient access using FHIR and open APIs, the transparency and coverage, we all call that price transparency rule that already is required for hospitals, but we see kind of a mixed compliance with it. And we have the No Surprises Act, which has a lot of scary things in it about how we might have to publish and collaborate, not only prices, but honor estimates, so provide estimates before services and honor them. Those are all very transformative, things that were never required before in healthcare. And then we've had the pandemic, and we had all hoped so much that we'd see the end of it. And now, we're all worried, are we just starting a new phase of it now? And that pandemic has caused so many of us to turn to digital engagements, virtual health, telehealth. You even see practices now beginning to ask people to fill the paper forms out online before they come to the office. Things that you would have thought that some of our physician practices would have stayed on paper, like that HIPAA compliance form that I don't know how many times I've filled that out in my life and signed my name on it with the date and never, ever looked at it again. I've now been to facilities where these are online forms. Very, very different. You even see that some providers and hospitals are using kiosks, and they're having touchless registration. So there's a lot of differences. And, the pandemic, where people don't want to be face to face with each other, is changing that. And we would have not expected that in healthcare, 2 years ago. And we also have a true, I think, deep interest in social determinants of health, health equity, bias in our decision support systems and in our approach to healthcare. And that's really all top of mind right now. And many organizations are trying to navigate those challenges in new ways. You know, behavioral health apps are really taking off. We see people trying to find ways to support the financial challenges of serving healthcare. We see connected devices. We see transportation services. We see home health emerging. You know, Janice, I think, is going to talk some about this later. All of these things are transformative. They're moving data across barriers. They're doing all kinds of things differently, and they're being driven by compliance, which is just so odd. You know, typically we're also frustrated by compliance, and compliance isn't helping us. But all of these things are coming together to help us meet these challenges of virtual care, home care, connected care, and helping those who are challenged, either challenged physically, challenged financially, or challenged just by the nature of where they live. And it's wonderful because, you know, I went into technology to solve problems. And it's great to see that we can take technology that we have and help people. But, you know, what I see as someone who's sat on the other side of the table and been a technologist working in industry is we just can't do this one at a time. We have fatigue right now, program fatigue. We've been doing so many programs. If we just start trying to do this one thing at a time, our teams are just going to be exhausted. So I feel strongly that we've got to start building out a platform that helps us with low code, a platform that is API first, a platform that gives us the building blocks so our technologists can take these components and put things together quickly. We can share data with our partners, because I don't know of a single organization that can check all the boxes I spoke of earlier. Everybody is partnering to get things done nowadays. So we have to pull this whole new way of thinking together. We have to take our existing technology, API enable it, and give both ourselves and our partners the tools to build new things much more quickly and easily. And as Wanae and I like to say, refresh and reuse, or reflect, refresh and reuse is like one of our mantras together. And I think if we do this, we get the toolkit we need to make a difference, make healthcare affordable for everyone, for our clinicians, to give them a better experience, less typing, less keying, to give our patients a better experience, and to help our administrators and plans and other locations who need this administrative data to take action. So, you know, I think it's just such a cool time, challenging, but very cool for us in industry right now.
Thank you, Ruby. I think that was a really great overview for what we're talking about being responsive and proactive and really being forward thinking, not just kind of starting from scratch, but just building one layer after another layer after another layer. And that's how, you know, that's how we remain flexible and how we, you know, meet the needs of patients, providers, and our customers in general. So thank you so much for that overview for everything that's happened this year, because there were a lot of things that that passed this year, some that that still have yet to be passed, but that was a really great overview. Thank you. I'd like to invite Colby now to share his thoughts, and let's pull up the slides, please.
Great, thank you, Juana. My name is Colby Tyner. I'm the Health Policy Manager for the Council for Affordable and Quality Healthcare. What I want to touch on today, we're all aware of the No Surprises Act. It was contained in the Consolidated Appropriations Act of 2020. It was signed by then President Trump. I want to focus on a very small section of the act that had to do with provider directories. It was Section 116. It had an assortment of provisions of it that had to do with provider directories and facilities and health plans, and also had to do with some miscellaneous provisions here that I'll get into here. So if you go on to the next slide, please. So this kind of leads up to the Provider Directive Provisions of the No Surprises Act. The ACA in 2014 added millions more to health plans. I'm sorry, I'm going to move here a window here, which put a spotlight on the directory accuracy. More people on healthcare roles, relying on the information contained within provider directories. And of course, it put a spotlight. It put incorrect information in a fishbowl. Incorrect provider data has led to increased complaints, resulting in additional federal and state guidance, requirements, and legislation. CMS issued guidance for 2016 for Medicare Advantage plans that they can be fined for provider directory errors. Lawsuits began being filed for inaccurate data. CMS increasingly saw communication between providers and health plans as a two-way flow of information. So that all builds up to the provider directive provisions of the No Surprises Act. So next slide, please. So if you're not unaware, I talked about how there are two main sections of the provider directive provisions here. This goes into the requirements for health plans. Maintaining a database of provider directory information be one. A launch a verification process to update provider directory information quarterly. That's every 3 months. This has some ramifications for what the states are going to be doing here in the next couple of legislative sessions. So we can get in that too in subsequent slides. But they're also required to implement a process to remove unverified providers quarterly. Execute a process for updating provider directory information within 2 days of receipt from the provider. There's some questions regarding this particular provision in terms of what constitutes contact. So we'll get into the rulemaking here in a little bit. Implement a response protocol that ensures the provider's network status request is responded to within 1 business day and communication is maintained for 2 years. And of course, they were also required to post their respective balanced billing protections that they have. Next slide, please. This is the first foray that the federal government has had, actually, governments at any level have had in terms of requirements for providers and facilities on provider directories. And so providers must ensure the timely submission of provider directory information. They also, they're also required to submit when they begin a network agreement with a plan with respect to certain coverage, when the provider terminates an agreement, any material changes to the content of provider directory information, or any other time determined appropriate by the secretary, and that of course is HHS. So next slide, please. This is very key. So I talked about how health plans are going to be required to, as of January 1st, to update their provider directories quarterly, every 3 months. There's a provision in this section that has to do with the preemption of state laws. So, for example, if it basically says that if a law or regulation on the books in the state at the state level preempts these provisions here in the No Surprises Act from being implemented, that law or regulation is nullified. So, for example, if a state requires health plans to update the provider directories every 6 months, that law is going to be nullified. If, like, for example, a regulation that was enacted earlier this year in West Virginia that requires health plans in West Virginia to update their provider directories monthly, that regulation will remain on the books. And so there are some questions regarding what this really means in terms of what provisions of the No Surprises Act will actually fall under the state preemption, and which provisions will not. And so we're hoping that the upcoming rulemaking here expected after the 1st of January will actually go into this. There's actually, there's also some questions regarding oversight. What provisions of the No Surprises Act, particularly the ones that have to do with provider directories, will fall under the oversight of the states, or which ones will actually fall under the oversight of the federal government? Next slide, please. This is the current legislative and regulatory landscape of provider directory updating requirements at the state level, and this is up to date as of today. It's color-coded. You see the states in dark blue have no requirements. The states in the lightest color actually have monthly requirements. So you see the breakdown here. And this will be this is a fluid resource that we have that we continuously update. So you see the breakdown. Next slide, please. So there's another provision in the No Surprises Act, at least in the provider directory section, that called for the first batch of rulemaking to be handed down as of July 1st of this year. That did occur, and so the first one was dropped. have to deal with the air ambulance stuff. And I also teased that a rule on the provider directed provisions is going to be coming after the first of January 1st, 2022. You see the subsequent rules that were dropped that had to do with independent dispute resolution process. And there was a guidance that had to do with that basically said that if plans were not in compliance with provider directed provisions as of January 1st, they were not going to be held accountable as long as they held to a good faith and reasonable interpretation. So the respective problems that this presents, the law as it is written leaves a lot for the states to pick up. And so I talked about the state preemption clause that said any law at the state level or any regulation at the state level that impedes the No Surprises Act from being implemented, that's going to be nullified here. So that needs to be explained a little bit further here. The pre-filing period at the state level in terms of the legislative session has already actually started. State legislatures are going to be convening. 46 of them are going to be convening as of 2022. Most of them will start in January. So what do they have to respond to, at least in terms of the provider directed provisions of the No Surprises Act? There isn't a whole lot. And so what we're expecting is any kind of legislation that has to do with the No Surprises Act is not going to touch on the provider directed provisions as of yet. It's going to focus more on the air ambulance stuff, the IDR, and things of that nature. So next slide, please. So going, I know this has questions here, but going a little bit further here, we expect fully that the rulemaking post January 1st is going to go into things like state preemption, federal or state oversight, federalism. What parts of the No Surprises Act will the states have control over? And what parts will the federal government have control over? What kind of penalties can be assessed for noncompliance? Who's going to have oversight over the penalties? We also expect the rule making to explain what kinds of information are going to be expected from provider networks. There's a little clause in there that says they're going to be expected to submit digital content information, for example, to health plans. What does that mean? Is it email address or is it APIs? We fully expect the rulemaking to get into this because we're hearing a lot of questions from our member health plans regarding this. So questions regarding the No Surprises Act, particularly the provider directed provisions and what we're expecting for rulemaking?
Thank you, Colby. That was very enlightening, actually. I think it's interesting that there are actually a lot more questions than answers, especially around all these regulations and the No Surprises Act. So there are a lot of surprises that are still coming. And in terms of provider directory, it's obviously not as simple as rulemakers probably assumed it to be. And that it is a very complex issue, and here we are now with all these regulations that have passed, and there's still some pieces that have not passed, and there's still some open questions. So I do want to remind the audience that if you also have questions, because that was a lot. I actually had some questions myself. If you have questions, please submit them to the Q&A, because I think that Colby really outlined something very important. It's that yes, there are regulations, but there are also these remaining pieces that are uninterpreted and that still leave some things open to questions, and still, people are responsible for implementing what they don't possibly 100% completely understand. We find that often is the case with policies. There's some downstream unintended consequences sometimes, and things kind of get worked out as we go along. And so continue along this string now. I'd like to invite Janice here to talk to us about what else don't we know and what else should we be worried about this year, and then I'll invite everybody back to talk about what's the prediction for next year and what are the challenges. Janice, please, welcome.
All right, and yes, and I will be looping back to some of the things that have already been said, but I want to actually start with prior authorization. About a year ago, CMS put out a draft interoperability rule that featured a variety of prior authorization requirements. It also had some other improvements to the previous May 2020 interoperability rule that Ruby referenced. The public was given 17 days to comment. That included the entire holiday period. And then the rule was published as a final rule in early January. It was clearly a little bit rushed, and it had some inconsistencies among other issues. And then it was frozen when the change of administration happened. It was supposed to be frozen for 60 days, but it's still frozen now. So in addition to directly requiring electronic prior authorization workflows and pathways using FHIR APIs, with a strong preference, but not quite a requirement, that they use the 3 Da Vinci prior authorization implementation guides. And we can, if you want to know more about that, you can ask them the questions. But the rule added both prior authorization data and new reporting requirements to each of the existing APIs and exchanges, the provider directory APIs, the patient access APIs, and the payer-to-payer exchanges. It also had some other new stuff. It added a new provider access API requiring FHIR API data exchange from payers to providers that included claims and administrative data, as well as payers to send providers what they had in the way of USCDI clinical data. It also required that payer-to-payer exchanges use FHIR. The rule that is finalized did not require FHIR. It strongly recommended it, but it did not require it. So that's the rule that's frozen. Now, I personally think that it's unlikely that the rule will be resurrected exactly as it is, but I do think that the 3 areas that I just talked about specifically, some form of electronic prior authorization, a provider access API, and requiring payer and payer exchanges to use FHIR will come back, and possibly some of the other pieces as well. Exactly what format and exactly when, I'm not positive, but I think that we should all look for those things to happen. I don't think the fact that that rule got frozen means that those things have gone away. But that's only one of the things that happened this past year that may have future implications. Colby mentioned the No Surprises Act. And one of the things, and while there is, and he talked about stuff that still needs regulation, specifically in the provider directory, we'll come back to that. But one of the things that was really interesting about No Surprises is that it's the first time I saw, there are always some holes in the regulations and some things you have to figure out, but they explicitly indicated that they want you to make what they're calling a good faith attempt to comply with the law without having any regulations on several pieces of the No Surprises Act. And there's really 4 major categories where they did that. One of them is the provider directory, but there's also some insurance card provisions they did that for, continuity of care provisions, which is a big one, and then also notice of rights and disclosures that are required. So that last one basically is what you have to tell members and patients, whatever term you want to use for people, about their rights around No Surprises. And one thing that was interesting, when the guidance was given that you are still supposed to try to implement this, but there isn't going to be a regulation. They specifically mentioned that there were sample notices that would definitely constitute a good faith attempt to comply. So I would take that as a pretty big hint and use something, if you're not them, something very close to them as possible, and then you're probably covered. But regardless, even though there's no regulation about this, it's supposed to be done. Another area is continuity of care. There are no known notes on what constitutes a good faith attempt at this. The law, but the thing is, the law as written says that in-network benefits must continue for ongoing care for at least 90 days after a relationship is severed between a payer and a provider. So if there's something that's in process or already underway, even if the provider is no longer part of the network, they still have to be treated as part of the network for at least 90 days. So that's going to be interesting, and what constitutes a good faith attempt to implement something like that. All of these things are for the plan year starting after January 1st, 2022. So some of these things need to be in place in less than a month. Another big area, the one that Colby talked about a bit, is the provider directory. And the one big piece of guidance that has been released is that in order to be considered a good faith attempt to comply with this, you absolutely must have in-network costs, in-network deductibles, and in-network out-of-pocket maximums applying to members if they were given a reason to believe that a provider or facility where those things were incurred were in-network. The other thing, that 90-day review period that Colby mentioned, if providers who can't be verified, if you can't verify that providers that information is correct, you are obligated to remove it. And you also only have 1 business day to respond to patient member requests for information about whether a particular provider or facility is in network. So I believe that those components probably need to be there in order for this to be a good faith effort to comply with the law. The last big piece of this is insurance cards. And there were some requirements for what had to be on an insurance card. And you need to make an attempt to do that again for plan year starting on or after January 1st, 2022. You have to include the major medical deductible, the major medical out-of-pocket maximum, and telephone number and website address to seek consumer assistance. And that also has to, either separately or as part of that same telephone number and address, has to allow someone to access information about any additional deductibles or out-of-pocket maximums. So if there's a separate medical and pharmacy information, they need to have information on how to access. The pharmacy information doesn't have to be on the card, but they need direct information about how to access it on the card. So that's the sort of the second big area. I know I'm covering a lot of ground quickly here. The last area is sort of what CMS has indicated what some of their focuses will be. And they've sort of pushed out 5 priorities. And I'll talk about some of these in a little bit more detail. But first, the priorities are enabling AI and machine learning while retaining privacy and security, improving interoperability for post-acute care, additional provider directory stuff, HIPAA administrative simplification, including the adoption of ICD-11, and consolidation of quality measures across the industry. So the quality measures work is already underway, but very little detail about specific plans in this area have been released. They've just already said it's a priority. They've started reviewing what's out there, but they haven't really talked about exactly how this consolidation is going to work. But they're definitely looking to do this across all of the industry organizations and specific payers. And they're hoping to not have to have 8 gazillion different quality measures out there. Provider directories have been included in some form in almost all of the recent regulations. So continued focus on that is not surprising. They have not specified any specifics about what they're looking at to adding to those types of regulations. All right, big one, ICD-11. ICD-11 was adopted by the World Health Organization in 2019. It becomes a valid, usable standard on January 1st, 2022. With the exception of ICD-10, the US has always adopted new versions of ICD within 4 years, and usually within 2 years of them being adopted by the World Health Organization. ICD-10 actually took 23 years to put into place, to give you an idea. So clearly CMS is looking to push us closer to the previous adoption periods of 2 to 4 years, but there have been no actual, it's not implementable until next year. And there's no sense of whether we're talking about 2 years or 3 years or 4 years or more for the adoption, but they're clearly looking to do that soon. The post-acute care interoperability is also a little bit unclear. There's an industry group that's called PASIA, which stands for Post-Acute Care Interoperability, surprisingly enough, that has done some work in the area, but they're not an official HL7 accelerator. Some of the work that they've done has been very focused on distinct and specific bits of care needs rather than sort of a holistic view. And it's not clear that CMS is planning to work with them. So what they're planning to do in that area isn't clear. There are some clauses in the proposed CARES version 2.0 act that's in Congress right now that also touch on post-acute care, but they're not necessarily looking at data exchange or standardization beyond possibly portals that help people find beds for patients. And obviously that's also not a passed law yet. The last area is AI and machine learning. That's come up more with ONC than CMS to date, so it's not clear what they intend to do here either. There's also some FDA oversight here because some algorithms and machine learning software falls under the FDA definition of medical devices. but a lot of it doesn't. One thought here is that the Mayo Clinic and a few others have floated the idea of a nutrition label that offers more transparency about both the algorithms and the data. Reducing bias is also a big push, both in the processes used for AI and in the training data set, but it's still unclear what CMS's role in that is. So I think I'm about at time, and I will hand back to Juan at this point.
Thank you, Janice. That was a lot of information. I think that was absolutely fantastic. Sorry, I heard something in here. Sorry about that. I think you really laid out a number of things that again, things that we should be thinking about. A lot of, really digging into the understanding of what these regulations actually mean and how people are forward thinking. So I want to kind of shift the conversation a bit. We talked a lot about, and we've heard a lot about, the things that have happened this year from many, many different perspectives. And there's Ruby. We've talked about things that have happened this year, and we've talked about some things that have to go into effect in January 1, 2022. So the question I want to pose really is looking more broadly at the year, because there were some things we kind of touched on, right? There was the continuity of care that we talked about. There was the impact on providers. There was like the impact on patients, just the impact overall on the industry. So I just want to kind of get from each of you, and maybe I'll start with Ruby. What do you think? What do you think is really going to happen next year, and how do we and who really should be solving these challenges? What should we be thinking about when we're trying to be forward thinking? What are the things we should be thinking about when we're trying to be forward thinking and thinking about what's going to happen in 2022?
Yeah, that's great. So this is like a really tough question, Juane, because we just listened to me, Colby, and Janice just like fire hose us with all of these things that need to be top of mind. And what we know is that compliance is spotty across the board, right? So, and if we have any regular EHI attendees, they know that in some of our prior conversations we had Blue Cross Blue Shield of North Dakota on that reflected on their learnings. And I think they're a really good model because they're a smaller mid-sized organization, right? They don't have a huge budget. They don't have 10,000 people. So, one of their reflections is the data integration problems are so much harder than we thought they would be. And that our partners are changing their minds about how they're going to do things. So you have to plan for change. So I think that the first thing we need to do is pause and reflect and replan. But there's a few things that Colby said you have to do, right? So this provider directory has some teeth in it. There are some penalties that have been published, so we need to replan. We need to take action with some priorities like the provider directory. And I think it's a chance to catch our breath from a lot of people were sprinting to get that patient access FHIR API up and running. Catch your breath and then start to look for automation, because you need to automate so that you can comply effectively and on time. As all of this buildup that Janice alludes to is on hold, when that releases, are you really going to have time? And so we have this long history in healthcare. If we don't have a date in front of us, we just put it aside, we deprioritize it, we stop thinking about it. So my advice for next year is get serious about strategic planning. You will be using FHIR APIs. They will be changing how you do business, not only with your patients, but with your provider partners if you're a plan, or with other plans if you're a plan. And think about how you're going to publish provider directory information and pricing information, because that's not going away. It's bipartisan. It's here. Try to make it API driven, because you can't afford to keep changing things in your code and meet the schedules.
Yeah, that's great. Colby, I see you shaking your head. What are your thoughts? Can we catch our breath? Should we try?
I don't know. I mean, to add on to what Ruby was saying, we have a long history, at least in terms of healthcare in this country, of opening up the jigsaw puzzle box, dumping all the pieces down, and then just taking our time to try to put the pieces together. And it's a vicious cycle that we've continuously operate within. And the No Surprises Act is actually a good example of this. The states are going to have to put the puzzle pieces together. The commercial industry is going to have to put the puzzle pieces together. And so who's going to be the oversight here? It's a good question that I honestly don't have the answer to. I don't think anybody has the answer to. And so another point that Ruby was making regarding APIs are fast becoming ubiquitous. And I mentioned the digital content information clause, that providers are going to be required to submit digital content information to healthcare plans for provider directories. What does that mean? Honestly, when I first read that, I thought that just meant email address. But as time has gone by, I'm starting to actually personally believe that it does refer to APIs. So how many providers know what their API information is? There's a provider education aspect to that that's going to have to take place. And so that's just another, big section of that jigsaw puzzle that we're going to have to put together here. And what the real answer is on how to do that, I really don't know, but it's going to have to take place.
And
Yeah.
I will build on what both of them said in a way. I think that two of the things that I think people need to keep in mind is that, and I'm a tech person saying this, there's all kinds of great new technology to help with this, but the processes are just as important, if not more important. And healthcare is used to having a really slow, in tech terms, waterfall type process where you plan things for 9 months or a year or 2 years, and then you move things along for another 5 years, and you have contracts that require things to be in place for 2 or 3 years. And that's just not going to work. We need to be more agile. We need to think about implementing things in an agile way, writing contracts in a way that supports this, putting in place processes that allow for fast iteration and fast swerves. A year ago, no surprises wasn't even on my radar. And I've spent most of my time looking at it for the last several months. That's certainly, that's been one of the things I've spent more time on than anything else. And you just don't know. You can't plan things like that. And the other thing that I would say is that, as more and more healthcare gets digital and more people want to use, whether it's mobile apps or apps on their computer or other types of digital intervention, there's also a tendency to think that all of that comes for free. And that, one of the, like with the patient access APIs, if we build it, they will come. Well, not if you don't make it reasonable for the app developers to actually find your APIs and work with your APIs and test your data. Not if you don't tell people about it. Not if people don't understand that that's available. And so there's another player that we haven't talked about at all so far, which are some of those app developers and some of the people who are trying to build the peripheral services. And that might be mobile apps, that might be smart on Fire apps that'll help make Fire easier to use at provider organizations and some of these things possible. And if we build it, they will come, doesn't work, or just doing the minimum, you have to actually build it in a way that's usable and takes into account all of the different people and roles that need to use your stuff.
Absolutely. That's interesting you say that, because it takes me back to a conversation we had earlier this year with a developer actually on one of our webinars, who said that thinking about how we become compliant and meet what we're required to do as developers, like put the developer first, put it at the center of the challenges that the developers, that they're going to be faced with. We're trying to meet these regs on time in a way that's useful and cost effective and can be very, very quick. What comes to mind, and I wonder if any of you have any thoughts about this, I'm thinking about, what about the smaller systems? Like how can they keep up? It feels like, and I agree with you, Janice, we shouldn't take this approach of if you build it, they will come, but that seems to be our theme across, healthcare. We assume that if we put a solution out there, everybody's just going to just run to it and take it and just kind of like run with the ball. But the fact is that sometimes there has to be support in place first, and there has to be necessary resources to even reach the building that we've now, I want to get there, but I can't. Do any of you have any thoughts about how smaller systems should be thinking about this? Someone mentioned like provider education, which is also, I think, a really key component as well. But do either of you have thoughts? I see Colby and Ruby shaking their heads. Janice, I'm imagining that you are. Would you like to answer that?
I'll take a first run at it. I mentioned that this was particularly challenging for smaller organizations. I really think that's part of why the hospitals have not gotten the prices up properly. You know, many of our smaller organizations rely on vendor software. So if you have an electronic records platform, it's very rare for it to be installed on-prem anymore. It's in a cloud somewhere. The vendor's managing it. If you have a registration admission system, it might be the same vendor, it might be a different vendor. Again, it's not managed by you. So I think it's particularly hard to do all of these portal-oriented things. Portals for third-party developers, portals for patient access, portals for price transparency, portals for the provider directory. They have to be so much more dynamic. They're not a static page. So that takes a more qualified programmer. So I think this is one of the things where you're really going to have to think, can you hire this type of person yourself, or do you need a partner to help you? And so, you know, I know that Colby's organization is trying to help people identify those who do have provider directories and are compliant and make things public. So he might have some more conversations, but my last little bit would be learn who is helping. Like as they say, look for the helpers. CQH is trying to help, Da Vinci's trying to help. See if you can find a helper, because it will be hard for you. Go ahead, Colby.
That is a big role that we play. So for example, the No Surprises Act, when the provider directory provisions were, we analyzed them, we turned around and we communicated with our member plans on implementation. And in fact, we made some adjustments to our technology to help our member plans be in compliance with the No Surprises Act. We started doing alerts and timestamps, for example, as to when they actually last updated the provider directories. But I'll speak to the question again. There's a reason why the consumer-facing telehealth market has taken off considerably, the Teladocs of the world. If you're a patient that's in a rural area who your immediate access to a hospital likely does not have the infrastructure to use telehealth, or if that's assuming they even have broadband, for example. So where are you going to go? You're going to turn to the consumer-facing market, the Teladocs, the doctor on demand. These smaller systems are kind of behind the 8 ball when it comes to the progression of the technology. And so that speaks to your question. They are behind the 8 ball in some cases.
Yeah, absolutely. And, you know, and hopefully with investment in infrastructure, maybe there'll be some catch up. But I think, again, it's an example of playing catch up, right? Not necessarily being proactive, but, you know, being reactive. And I imagine for the three of you that it's very difficult to balance reactive with proactiveness, right? Because you want to proactively kind of look into a tunnel and see these trends and kind of look behind and kind of be ready for what's coming, you know, proactively. But at the same time, you know, have to balance, you know, your reactiveness. But, you know, what do we check first? You know, so I want to get some insight into, so how do you prioritize that? You know, how do you decide if we take a date away, you know, how do you prioritize what comes first, chicken or the egg, right? I mean, because it's like all, you know, it's everything at once. Janice, you have something that
I wanted to make a really quick comment on the last point too, if I may, which is that it's really interesting because APIs in general were designed to support the small user. That was part of how they were first put in place. And so this idea of moving that way, and I think in the long term, it will help the smaller organizations because there's more standardization. If you can do everything the same way with everyone. It's just getting to that point. But you know, on your topic here, how do you prioritize? I think one of the things that you can do is see that there's a common set of things that are kind of there. There's the idea that all of your data should be standardized. There's the idea that you should look to use APIs, in particular FHIR first. Now, FHIR is actually a framework and not a specific API, so you actually then have to go in and define the specific APIs. But this idea of having as much standardization as possible, thinking about things in this way, you know, and it's kind of the platform idea that Ruby raised earlier. You have this common core of things that are in place to enable faster development. As far as what comes first, you know, it's really going to be what the pain points are in your organization, but possibly sometimes what your boss thinks is important, as much as we don't want to say that's still something your boss, the people who are doing the work, their boss tells them to do something, they do it. And some of it's going to be where you're, again, to go back to the non-technical things, where you're at in your contracting, if you're kind of locked in for things for 2 years in one area, but you're not as locked in in other areas, you may try to do those other areas first. So there's a lot of different things in there. I mean, it's hard when there's like 80 things and they're all supposed to be done at once. And you just have to do the best you can.
Hey, I want to chime in just a little bit. Love these comments. Like, so true what Colby said, what Janice said. Like, Janice is always authentic, and I love that. If your boss says it's a priority, right? So true. I just want to remind people to remember security. If you only have a limited number of resources, really make sure that you didn't expose your Fire APIs raw. You need to have a security layer, because there's a lot of information out there, the ransomware. Now there's something called killware, which scares me to death. But we need to put a security layer on. Even though you have to expose these things, your provider directory has to have an electronic download. You're going to see prior auth happening. You're going to see all this. You still can require the developer or the individual to register. You can collect information about them. You can ask them to go through a test cycle before they get to production. And if you see suspicious behavior, you can suspend them while you investigate it with them. And to Janice's point, that's where automation and processes, you need processes. So if you didn't write your security processes down, if you didn't align with your CISO, if you haven't coordinated with your call centers so they know what to do when someone calls them with a problem, take the time to catch everyone up on what's changing.
Thank you for that. Colby, do you have something to add? I saw your head shaking.
No, I think Ruby is spot on. I mean, the way we prioritize how we attack these issues from a proactive standpoint is that we listen to our member plans in terms of what their concerns are. Our technology platform is intended to be, it's designed to be malleable. Maybe that is reactive in a certain sense, but it's designed to be proactive. We create a one-stop shop for healthcare data. And by making it malleable, we listen to our concerns, the concerns of the member plans regarding the No Surprises Act. And one of the things that did come up was the implementation date of January 1st for updating your provider directories from a quarterly standpoint. And so it was an easy adjustment to our technology to ensure that we were helping them be in alignment with the No Surprises Act. And so prioritizing, it just means listening to what their concerns are and making adjustments accordingly.
And I would also, I'm sorry, Monet.
No, go ahead, Janice, please.
I would also add that when you can, collaborating is important. I mean, that's a lot of what MHGC is about, bringing together the payers and the providers to discuss how to do these things. And having, so those standards that I talked about before, having those defined, even if it's among a smaller group than everyone, is really helpful. And then you can expand that to more people. And having that discussion of, this is what we're actually seeing, how do we deal with that, how do we build that into the standards that we're doing for everything, I think is also an important part of both of the last few types of things we asked about.
Absolutely. Collaboration, I think, is key across, no matter what area we're looking at. I think collaboration is definitely key. And as Colby said, just listening to the needs and listening to the concerns and, addressing those head on, excuse me. I do want to ask one more question about data. We have about 5 more minutes. So I want to ask this last question, then I'll turn it over to the panelists to sort of give the closing remarks. So we talked about, someone mentioned data standardization a little bit, and that is a huge topic, right? That is one that no matter what conversation you're talking about in health, like that's really top of mind. Do you think that overall, just in an opinion, are we making progress towards data standardization? And probably even a better question is like, how do we define that? Are we even going in the right direction? Because there's so many people that access data and collect data, so what do you think about that in 2022?
I have a lot of thoughts about that.
Bring it on, Ruby.
First of all, we have to get real. I mean, I really do appreciate the data standardization issues, but our implementations didn't put data in standard fields.
Mm.
So we have a real challenge because we have a history of not caring about data. So we've got to do more. I'm going to have to pause and catch it.
I'll chime in there.
Yeah.
I'll fill in for data standardization is more about just defining the standard fields in the exchange. You know, as Ruby was saying, I mean, that's an important part, and I think we have a lot of work to do there. And I think that one of the issues along that is not doing quite as much slicing and chopping as we have. You know, 90% of the data is the same everywhere. We don't want to come up with a different definition for something when you're using it for quality measures versus, you know, like care management versus something else. You know, it's important to have it be standardized across the industry, but that's not, the data standardization is more than just saying this is the data. It's understanding exactly how that is. If you don't want to use that standard internally, that's fine, but you need to understand how to map to that standard with what you're doing. And if you don't use that standard internally, then it's your responsibility to know how to do that mapping and to understand that you have to do it and to be that part. And whether that's your vendors or the organizations themselves, I think that's a big piece of what people are missing. And that's a hard work. I mean, I've done that in the past. Data mapping is hard. But if you're not going to use, you know, you either have to make a commitment to doing it once and changing all your stuff to something that you expect will be a standard for a while, or understand that you're going to have to do that mapping and just take that as part of your process.
Thank you. You helped me out, Janice. I'll just say one more thing. We really need patient identifiers. We don't get patient identifiers. Our confidence in exchanging data with each other is going to be weak. And I know we don't want to do this as a nation. It's always been a challenge. We're just really hesitant to, but and I know there was a pre-question about patient proofing, identity proofing and patient verification. I don't think any amount of machine matching isn't ever going to give us 100%, even with AI, machine learning, probabilistic techniques. We really need to make it easier to exchange data.
Yeah. Thank you, Ruby. With 2 minutes to go, Colby, I'll let you round us out with that. Like, what are your thoughts on this?
I'll follow up too, and maybe this is a prescriptive rather than creating a solution or voicing a solution here, but we're still so siloed in terms of our healthcare system, from the primary care environment to the pre-hospital environment, to the hospital, to the post-discharge environment. It makes it very, very difficult to create a collaborative environment for data research purposes and creating better patient outcomes and easing administrative burden. So until you achieve the removing of the silos, data standardization is going to be very, very difficult.
Excellent point. So with that, I do want to thank everyone for joining us today. It sounds like, you know, there's a lot of work to be done, and there's a lot of work that we're going to continue to do in 2022 and beyond. You know, today we talked about the regulations that have been passed this year and some pieces that were not clear. There's a lot of ambiguity around these regulations, and that in itself is a huge challenge and one to overcome in organizations. And within those regulations and responding, there's a piece around data. There's a really important part of data and standard standardization and the collection and for those who are accessing that data. As someone put in the chat, you know, there's a problem with HR vendors not following the standards, you know, and not being able to catch those mistakes. And I think that's a really important point to make, and everyone, you know, want to really be aware of. And it's absolutely true. Data is very critical to everything we're doing in the industry. And it also it supports all the things we're trying to pass in regulations, right? Price transparency, that's opening up data. Provider directory, that's opening up our data. So with that, I do want to leave you with those closing thoughts. I want to thank our panelists for their eye-opening explanations of everything that's happened, you know, lighting the fire and putting the water out, letting us know that there's a lot that's happened, and there's a lot that we have to continue to work on, and we'll continue to work on coming down in the future. I want to thank everybody for joining us today. Thank you for taking the time to spend this 1 hour to talk about this important topic. And It's December, so I'm going to wish everyone happy holidays and a happy new year. And don't forget to join us next year in January for more educational webinars. And please keep in touch with ehidc.org. And again, thank you to Ruby, Colby, and Janice. Everyone have a great afternoon. Thank you. Bye.
Bye. Happy holidays.
Bye, everyone.
Thanks, everyone.